Assalamu alaikum. Thank you, Mr. Chairman, for the nice introduction. I'll be a little bit quick, so just to show you a lot of data. So I was given the task to talk about advances in scleroderma, a very close topic to my heart. I see around 300 patients since 2017. I have a large cohort of scleroderma. So I have no disclosures. This is the outline of the presentation. Unfortunately, over the last year, there was no major advancements in patients in scleroderma. And this is expected in a disease which is very rare and very complex. And if we look at the timing of the disease, I mean, it's a very complex disease. I was flipping the topic to another way of why don't we embrace what we have currently in the literature to try to make a usefulness of what we have in the literature to have better outcomes in our patients. And I think to do so, the first thing is to define the disease. I think, you know, this is the question that always comes when I see a patient with systemic sclerosis. When was the first non-Raynaud's phenomenon? And this is very important to define the disease because treating a disease earlier is better than treating it late. The second thing is also defining the disease is whether it's early. Early here is 5 years. When we look at rheumatoid arthritis, we talk about window of opportunity is 6 months. Here we're talking about a very long period of 5 years. And again, you know, whenever we want to apply what we know in the literature and drugs that are approved to our patients, I think understanding the cohort, the disease duration of the cohort is very important. Applying Actemra or tocilizumab in a patient who has a 20 years history of the disease is different than applying the same treatment in a patient who has the disease for 5 years. And if we are very, very lucky, I think we will capture the disease at an earlier even point, which is what we call very early disease, which is less than 24 months. So with this notion, I think I'll talk about a couple of the disease domains of systemic sclerosis. I chose 3. Let's start with cutaneous disease, and as we know that it's the limited phenotype is more common than the diffuse. This is what we know from the US, and when we looked at our cohort, we have around 170 patients. Actually, we found the flip in the region. I think the diffuse phenotype is more common than what we than the limited cutaneous phenotype, 80% versus 60%. If you want to take one PRL from this topic, I think modified Rodnan skin score is the most important scoring system that you need to use when evaluating patients with systemic sclerosis. This is one of the best tools to first diagnose the disease, and the second thing to assess the treatment benefit of the disease. Inshallah, maybe next year we'll have a workshop for fellows and junior residents. And it comprises of 51 points, and the higher the score, the higher the disease, and it's a surrogate of internal organ involvement. We used to think that if you have a higher skin disease, you have more chances of internal organ involvement. Recently, we realized no, it also depends on the biomarkers. If you have a positive HCL70, even in a limited cutaneous systemic sclerosis, there's a high chances of internal organ involvement. So there was some changes in the thought process about the disease. Let's go from what we know previously. These are the main 2 trials that, initially in methotrexate, there was very small trials, but very impactful initially in our practice. And if we look at Dr. Pop's trial, it was a negative trial, but when she did an intention to treat analysis, it went from a negative trial to a positive trial. And if we talk to Dr. Janet, she thinks if the trial continues maybe for a longer period, it will be a positive trial. So it's still used. I use it more in a phenotype of scleroderma that have overlap with rheumatoid arthritis. Mycophenolate came early in the 2027. There was multiple proof of concept studies that showed that mycophenolate may impact systemic sclerosis from different centers in the US and the UK. And then in 2018, we came with a very, very large cohort where we did a meta-analysis showing the efficacy of mycophenolate in patients with diffuse cutaneous systemic sclerosis and limited cutaneous systemic sclerosis. And we looked into the SLS1 and the SLS2, and we proved that mycophenolate at the dose of 3 grams, And if we look at our practice, how often do we use 3 grams in our practice? I think we are still under-treating patients with systemic sclerosis. And it showed that it's as good as cyclophosphamide, and if you compare to the SLS1, if even it's superior to what patients were on placebo. So this was one of the landmark studies that showed the benefit of mycophenolate in patients with diffuse cutaneous. Now, if we look at limited cutaneous systemic sclerosis, during the same analysis, it didn't show, it was the impact was not as much as what we see with diffuse. So it's more approved for diffuse cutaneous systemic sclerosis. In 2018, we were very depressed when the tocilizumab trial did not show any benefit. There was a trend of improvement, and if we talk also to Dr. Dinesh Khanna, he thinks if we maybe prolong the study of tocilizumab, we'll see a significant improvement. But there was what do you call it? A trend of improvement in patients who received tocilizumab. So you can't say that tocilizumab does not affect the skin, even though it's not significant, but there's a possible improvement over time. Most recently in 2021, we were amazed with this study. I mean, I think this also changed the practice, how we treat patients with systemic sclerosis. This was the first study where it looked into rituximab, patients over rituximab in patients with diffuse cutaneous systemic sclerosis. And then, if we go initially to what I alluded earlier, you need to know the disease duration. It's very important. Treating a patient 20 years is different than treating a patient 2 years. And if you look at the cohort, at the disease duration, these are patients with very early disease, less than 2 years. They had a mild to moderate MRSS scoring, and majority of the patients were also from the diffuse cutaneous subset. A very impressive data. I think we were questioning the data initially, that how impressive the data was. And then they had an open-labeled extension study up to 48 weeks, and again, we saw a significant improvement in the modified skin scoring. So also this changed the practice, how we, if we go back maybe 15 years, I used to use cyclophosphamide and evoluted to mycophenolate. And recently, if I cannot achieve a target of 3 grams of mycophenolate, I think combining rituximab with CellCept is something you need to think about. Maybe a 1 gram of CellCept plus a 6 months cycles of rituximab. A lot of trials are in the pipeline. Abatacept was a failure. I was part of this trial initially, but it was a negative trial. Benlysta is something, maybe there's some preliminary data, and there's other JAK inhibitors and other drugs, small molecules. IVIG is also a trial that is currently ongoing. I think there's problems with recruitment, but a lot of drugs are coming in the pipeline. Switching to a different domain of the disease, I think systemic sclerosis-related ILD is very hot topic. And if you look at those CT scans, you're always challenged who to treat, when to treat. I mean, always this question comes. Even when at a multidisciplinary team approach, we're always challenged who to give, even though they have the same phenotype, sometimes you put a patient on OFIV and the other patient on rituximab, so there's no right and wrong. I think, managing this disease at a multidisciplinary fashion is very important. Going back again to the DESIRES trial, improvement was not only in the skin, but there was a clinically meaningful improvement and significant improvement in the forced vital capacity and the DLCO. So as much as, it impacts the skin, it seems also it impacts the lungs. SLS3 trial, which is patients with a background mycophenolate, 3 grams with pirfenidone versus placebo. It was also, there was this was presented not last year, the year before. There was improvement in the FVC over 6 months, but over 18 months, the improvement declined or stabilized. I think since OFIV was introduced, I don't think we have too much interest in pirfenidone. I think we used to give it off-label in 2015, but currently I think because after the approval of OFIV, we have it's more prescribed. We still use pirfenidone in patients who are going for pre-transplant. Sometimes you want to maximize therapy. They're in rituximab, and you can put them on a dual antifibrotic therapy. Going back to the FASCINATE trial, tocilizumab over 48 weeks, again, it was a significant trial, didn't achieve the primary outcome, which is improvement in the skin scoring, but the secondary outcomes were improvement in the forced vital capacity, and it was approved. It was approved 2018. And if you ask me how many patients I have on tocilizumab, a little. And why? Because it's very challenging to know which patient phenotype or profile you want to put on tocilizumab. And I'm sure all of us are challenged. Do we put them on CellCept? Do we put them on tocilizumab? Do we combine therapies? And with such notion, I tried to maybe make it a little bit easier for you how to apply tocilizumab in your practice. So we have a couple of scenarios. So if you have an early diffuse systemic sclerosis with elevated CRP. So it was shown that if you have an elevated CRP, you are more prone to develop ILD. So with or without ILD, those patients are still prone to receive tocilizumab. And if the disease is worsening, the other options that you can use is either rituximab, combining it with mycophenolate, as we spoke earlier, or triple therapy, which is adding OFIV. The other scenario that we face sometimes is scleroderma ILD with absence of active skin disease with MSK symptoms. So about 40% of patients can have a clinical phenotype of rheumatoid arthritis. And sometimes we diagnose them initially with rheumatoid arthritis because they have a positive rheumatoid factor with a polyarthritis picture, and then over time they develop a skin disease. And those patients are also may benefit from tocilizumab. If we look at scenario C, which is scleroderma with positive SCL70, and again, going back to what I alluded earlier, that if you have a positive SCL70, even though you have a limited cutaneous scleroderma, you are more prone to develop ILD, and those patients you should be vigilant with screening for ILD, whether they have diffuse or limited cutaneous systemic sclerosis. OFIV also comes in mind, and I think the question that we're always asked, when do you start OFIV? Do you start OFIV after initially diagnosing patients with ILD, or do you wait? Do you put them on immunosuppressive therapy, and then over time you add OFIV? And I think we are still not handling the concept of treating hard or treating the disease earlier to what we apply in other diseases like rheumatoid arthritis. I think we should be more vigilant in treating. We shouldn't wait for things to happen. And I showed earlier the natural history of the disease. You don't want to wait after the 5-year course where you are treating just damage and you're just treating what you call placebo, So this is a simplified screening approach for scleroderma. Every patient should have a baseline chest X-ray. Each patient should have a high-resolution CT, and those are the red flags that highlights the importance or to be more aggressive or with screening. If you have male patient, early diffuse cutaneous systemic sclerosis, high CRP, ILD extent more than 20, and of course, if they have positive SCL70. This paper is still in press. We tried to further stratify the disease as subclinical versus clinical, and I think that the highlighted part, the risk of progression, is very important. This also can guide you on when to utilize other treatments other than the ones that we give, other than mycophenolate. And we defined the disease, I made it on the left side as a bigger zooming of the red box. If you have a high risk to develop ILD, and those are the same risk factors. And also we added risk of progression. If you have heartburn, if you have shorter disease duration, and other factors, I think those patients you need to treat earlier. And in the pipeline, a couple of medications are coming. IVIG, again, is something that I think there's a lot of investment in this medication. Switching to the last part of the talk, I think I have an interest in cutaneous calcinosis, and this is one of my patients, 39 years old, Emirati lady, long disease duration of 5 years from the first non-Raynaud's. She has diffuse cutaneous systemic sclerosis, ILD, cutaneous Raynaud's, digital ulcers, and if you can see, she had multiple autoamputations. And she has calcinous, and this is one of her X-rays. As you see, there's diffuse dense amorphous calcification among the volar medial aspect. And she took every medication in the world, anything you think of, methotrexate, diltiazem, rituximab, mycophenolate. She took even sodium thiosulfate, which is one of the trials that are ongoing currently. So what we did, we took part of the calcium deposit, and as you analyze the kidney, the stones for kidney stones, you can analyze the stones for calcinosis, cutis. So this was one of the most, the first proof of concept studies that we did actually. We utilized dual energy CT in quantification of those, because when you start a treatment, you want to know the treatment outcomes or the treatment benefit over time. So we utilized, I don't know if it's available in Saudi Arabia. It's a specific type of CT that's used mainly for gout. But we utilized to quantify the volume of calcium. And then what we did a baseline. We treated the patient with triple therapy. We treated her with colchicine, alendronate, and sodium thiosulfate. And we did a baseline, a quantification with DETECT, and then after 6 months we repeated, or 1 year we repeated the image to know if there's an improvement, and there was a notable improvement actually in the. So this is one of the, I think now one of the proof of concept trials that is currently ongoing, will be started in the US. I think it's one of the good utilities that you can use to have an idea about treatment benefit in starting patients with calcinosis cutis. I don't want to go in depth about calcinosis, and it's associated with patients with anti-centromere antibody, PMSCL70, and anticardiolipin antibodies. And this is just a brief outline on how to treat patients with calcinosis cutis. I think pain management is very important. Treating their anxiety is very important. Antibiotics is very important also. And if we look at the pharmacological therapies, the combination therapy is very important. We don't have, I'm sure if we ask all of us, I think it's very hard to have a very successful story with one medication. You need to combine medications. The most success I see is colchicine, adding it to bisphosphonates and sodium thiosulfate. And sometimes you need to add also a calcium channel blocker. So combination therapy is very important. You need to, patients need to be seen by a hand surgeon, and wound therapy is very important. Last but not least, I think scleroderma-specific autoantibodies are very important, and I want to talk on just one antibody, anti-RNA3 polymerase. We know that it's associated with scleroderma renal crisis, but I want to highlight your attention to malignancy. A couple of cases, just most recently with the positive RNA3 polymerase, elderly. One had a prostate cancer, one had a thyroid cancer, and the other one had a lung cancer actually. Had an anti-RNA3 polymerase positivity. I think initially this was from 2015. I wasn't too much, believer of the data, but I think with more practicing and seeing patients, I think we should be very vigilant with screening patients for cancer and patients with RNA3 polymerase positivity, and this was proved by multiple cohorts from the US and UK. And if we look at the age, I think this goes more than age. If you see a patient more than 50 with new onset Raynaud's phenomena and the positive RNA3 polymerase, you should be very vigilant with screening them for cancers, especially in males, prostate cancer. And with this, I would like to thank you for your attention. Inshallah, we'll see you next year for the other half.